All right, so can you hear me right? Yes. Well, thanks for Dean for introduction and for inviting me in the first place to come to CHOP and UPenn. My name is Zheng. As Dean mentioned, that I recently moved to University of California, Irvine. Before that, I was at the University of Michigan for 9 years. Started as an assistant professor and then associate professor. So it is my distinct honor to be here today. So CHOP, I have heard about the CHOP for a long time, and I have known some wonderful biomedical informatics work done at CHOP. So it's great that I finally had the opportunity to come here to meet with the folks and to give you a talk about some of the work I have been doing. So the talk today, I'm going to talk, it will be on quantifying the impact of health IT on clinical workflow. So the talk is based on some of the work that I did in the past. So it's not the most recent work I have been doing, but it's because I'm going to present some of the methodological advancement that me and my colleagues made. So I hope these methods are still relevant to you and your work. I'm going to spend about 10 minutes on overview of my work in human-computer interaction, and then I'll talk about the generally health IT's impact on clinical workflow, the overall picture about this particular domain of research, and I'll then present two sample studies. One is about workflow within EHR application, and the other is workflow, general workflow before and after health IT implementation, and how we quantify workflow from the pattern recognition and many other dimensions. And I'll conclude the talk using 5 minutes time. Overview of my work in human-computer interaction. So many of you know that human-computer interaction is about interactive design, understanding people's users' needs and users' preferences and constraints and so forth. So my work focuses on interaction design as well as evaluation. So in terms of designing useful user interface and for end users, and also evaluate the usability of the IT systems that we generated. So my work is particularly focused on clinical workflow, which is what I'm going to present today. I have also done quite a bit on cognitive design of healthcare user interface. So I'll go through that very briefly about what that is. So basically, if you have experience of working with electronic health records, you will know that the structured data entry is one of the biggest challenges of using such type of systems. So how do we improve the cognitive design of user interface that could facilitate the structured data entry is one of the research objectives that I have been trying to achieve. And so once you have the data in the system, the other challenging is how to get the data out for meaningful use and sense making. So information seeking, sense making is a challenge in following data entry. So how do you actually get data out and use the data meaningfully to generate valuable information? And related to that is information retrieval. So as many of you are familiar with, this is a very typical EHR design. So this is so-called structured data entry. Checkbox, drop-down box, and so forth, they constitute the main type of user interface nowadays for capture structured data. And we all understand why we want this, because this kind of data are computable, and we want that in order to maximize the value for reuse and for QI and for research. The problem is always this kind of user interface can create a lot of issues from the cognitive use point of view. So one study, for example, what we did is, if you see on the screen, there are always other text box that to accommodate things that people are not able to enter through structured format. So one study we did is about whether providing this kind of options might create some data quality issues. For instance, people may abuse these kind of fields, and they try to use order all the time. And it is possible because in some of the order entry studies, we know that certain clinicians, they tend to enter free text order information in free text box, and instead of filling out all the structured elements. So what we did is we designed a system, and we also provide order option. So you can open up the order option, which is an entirely free text box for people to fill in the data. So we studied whether clinicians might tend to abuse this feature. So instead of using checkbox, they actually enter a lot of data into the free text box. What we found is they are, at least in our study, we did not show distinctive behavior in terms of abusing this kind of boxes. So then we studied another feature, so-called exit strategy, meaning that, so in this case, we know that nowadays when we do structured data entry, we enter a lot of diagnostic information or other kinds of information which are codified. So you have to identify, say, diabetes. You need to enter 250.0, or you have to search for diabetes and enter that in a structured manner. And we rely on that diagnosis codes for a lot of different reasons: research, quality improvements, and even insurance claims. But it's possible that clinicians they have no idea how to actually specifically code a particular disease. And what we did, we actually got a lot of user feedback, and they strongly recommend we implement this feature, which is temporary holding code. This diagnosis is entered on a temporary code. And our study is trying to demonstrate whether adding this feature is going to, again, potentially being abused by clinicians who will be just using this temporary code to enter everything that they're supposed to enter. And the study also found that there's no significant abusing in terms of after we provide this feature. But we do find that it's actually quite helpful because sometimes what the person entered is indeed not very typical diagnosis that the clinicians in that particular clinic would enter. So this exit strategy is extremely important in a way that otherwise the EHR could slow people down or could entirely block their work, because without entering this particular information, they are not able to proceed with their next clinical task. And this exit strategy, I think, is provide them a way to be able to continue their work. So some other research we did is in terms of information retrieval and information seeking and sense making. So this is, again, very typical user interface design of EHR. So this is Vista, or commercial version of Open Vista from the VA. So information is presented in an organized way, but across different tabs. First, patient summary, problem list, medication, and so forth. So information then be presented into discrete boxes. So in order to understand the patient as a clinician, you have to actually read through those boxes and click into those tabs in order to assemble information about the patient to construct a story about the patient. So what we did is we designed a study trying to understand how physicians are using EHR system to reassemble information. In this particular case, admission handoff. So what we studied is the ER doctor. When ER doctor tries to discharge patients into a floor, they enter a negotiation process with inpatient doctors. Because inpatient doctors, they try to find as much information as possible to reject the patient because they are always overcrowded. ER doctor, of course, they try to find as many excuses as possible to send the patient off to the floor. So it's very interesting to kind of see what kind of information the doctors from the two different sides they try to pull out from the chart to back up their claims to send the patient or to refuse the patient. From this user interface, if you only have 5 minutes to read through the patient chart in order to understand the patient and try to come up with the argument when you enter negotiation, how do you come up with the most convincing information as quickly as possible? So we had this handoff study focusing on information retrieval and information seeking and sense making, based on this interesting dynamics between ER doctors and between floor inpatient doctors. And the other interesting study we did related to cognitive processing information is problem list. So how we find that problem list in Epic, in many other EHR systems, that's where a lot of information converge. So that's a central point where clinicians start to understand the patient. So we designed also a study trying to understand the rollout of a problem list. We found that very interestingly, different specialty doctors, they have very different understanding of what should be put onto the problem list and what should not. And because of that conflicting view, sometimes the problem list become overcrowded or become less, not ideally crowded. So people do not populate the problem list in certain specialties, and other doctors from other specialties, they actually complain about that. So I have to go through really quickly about some of the work related to each of those sub-areas. So the next sub-area that I have been working in human-computer interaction is computational crystallography and trace analysis. So computational crystallography and trace analysis, meaning that in the healthcare system, we capture a lot of data. In this case, security audit trail logs. So we capture this kind of data which tells specific, very detailed how clinicians access each piece of EHR feature, and also at what point in time, and also on which patient. So that give us a record that we can use to replay what happened exactly when the person is interact with EHR, which is the indication of the thought process, their mental model of entering data and also retrieving and consuming data. So in this particular example, for instance, so what we did in this particular study is looking at just the patient ID and see how the continuity of patient ID across a clinician's day of work. So as you see that this clinician is working on the same patient all the time, and then suddenly switch to another patient, and then return to the same patient. So what does this information tell from the user behavior point of view? So what could happen that causes this clinician to switch to another patient while he or she is working on the same patient?
They've got a phone call or something about the other patient. Possibly.
Yeah, they got a phone call, they got an interruption, so they have to close the covered patient profile and start the new one. Any other?
They might have remembered something they forgot to do or wanted to.
Yeah, the self-disruption, sort of self-interruption.
Possibly could be looking at another patient for something related to this patient.
Cross-referencing.
Yeah, for sure.
Yeah, so this part.
Yes. Viewing a document, but you can be asked to place an order on this other patient. Stop what you're doing, place the order, come back.
Yeah, also sort of self-interruption, because you start to remember something you forget to do about the other patient, and you in the middle of working with this patient, you switch to another patient. So this particular study, where we used security audit trails logs to detect copy-paste. So if you imagine that when people are doing copy-paste, you ought to open two patients in order to copy. Well, if it's cross-patient copy-paste, you ought to open up two patient profile in order to copy-paste data over. And this is a very strong indication. Well, there are many other reasons why this could happen, but copy-paste could be one of the potential reasons. It actually makes so we use this large log data so we can zoom in to specific events. Then we can start to actually look at the notes that this person, this clinician put in. Especially See, if you can see this is actually view the document and go back to start writing in other patient. That's a very strong indication that
also the elapsed time. The elapsed time
Yes.
also indicates that you probably went in there and just copied.
yes, precisely. So you were there only for a couple of seconds. Then that's a very strong 10 seconds. It's a very strong indication that it's not cross-referencing. It's not self-interruption. It got to be something related to copy paste or other related activities. So what I'm trying to show you is auditory logs. It's primarily for security. We use auditory logs so we know who is accessing what kind of data to detect unauthorized access of patient chart. But this data actually contains very rich information. And for copy-paste, if you want to detect copy-paste from the text, sometimes it's very hard because of the template text, because some patients, their records are essentially the same, automatically generated by the computer. But by looking at this auditory logs, you can actually see some very strong signals of copy-paste that allow researchers or administrators to zoom into those events. So that's what we call trace analysis or computational lithography. So basically, we use routinely connected auditory logs, phone logs, and pager archives, and all sorts of information that we capture every day. May not be for research purpose, but for archiving, for security auditing, but those data can be used to support very powerful human factor and human computer interaction research. Yes.
Kai, were you able to validate that?
Validate?
Validate whether in fact cut and paste was actually done?
Yes, because we actually have the data, so we know the patient ID.
That's what I was wondering. Yeah.
Yeah, we know the patient ID. I didn't show you some other columns, which is document ID. We actually know exactly what document this person is looking at, and that gives us a way to study the actual copy-paste behavior. Because if you don't have this information, if you go wild to all the patient records trying to see which documents were copy-pasted, it's very challenging. It's almost impossible. So the other type of research I've been doing also, we use computational methods, computational lithography, and trace analysis is using sensor device. So auditory logs give us a lot of information, but for certain behavior, such as the interaction between the clinician and provider, a lot of human-computer interaction studies are trying to make the computers more usable so that it does not interrupt the communication between doctor and patients. In order to do that, typically we use videotaped sessions, try to analyze people's gesture and gaze behavior and how they interact with patients when they use EHR and talk to the patient. It's very time-consuming and to code such video data, and it's also labor-intensive and subject to human errors. So what we did is we use sensor data. So we use we use eye tracking device right here. So we track the attention, and we also have a device which is connected to the computer, capture the screen activities. And we also have Microsoft Connect, which detects the body movements. So we have those multiple sources of data. Then we can automatically detect the body gestures and also screen activity, whether the person, the doctor, is actually looking at the screen while they're talking to the patient, or the doctor is just looking at the screen. And we have a screen capture, so we know where this person's attention is. So the bottom line is we do a lot of human-computer interaction research, but we try to use automatically connected data and also unobtrusively connected data. Because my research is more about trying to understand the actual behavior instead of simulated behavior. So those are some of the major studies I did. And from a methodological point of view, I'm a strong advocate for mixed methods to do human-computer interaction research. So I believe that quantitative investigations give us very objective measures, quantifiable results, but it does not tell us a story. And so we ought to use qualitative methods and also integrative analysis combining the two sources of data in order to better understand people's behavior and why they demonstrated such behavior. I'm also a strong believer of in situ studies. So in human-computer interaction, we have a lot of studies done in laboratory simulated environment, which is a necessary step. But we found very often in designing of health IT, the simulated lab sessions are not adequate to tell the actual user behavior, which is probably why we got so many unusable systems, because users' behavior, also depending on who the users are, recruited to participate in those experiments. So I'm a very strong advocate for in situ study. We study the IT applications as part of the user's job routine. Also saturated use, which is a very critical concept, but in health informatics evaluation research, we do not talk about that very much. The saturated use meaning after implementation of the system, how long do you wait? Say if you implement a decision support and you study 3 weeks after your implementation, you may find a very strong signal showing that your system is effective and people are paying attention to the alerts that you try to get them to pay attention to. What about 10 weeks after? What about 10 months after? Are they still paying attention to the same level of attention to your informatic intervention? So saturated use is, I think it's critical because a lot of times we do see that our users' behavior may roll back to their original level. They just do not have a sustainable use of certain informatics applications. The other one is non-intrusive. I'm a strong believer that when you observe people, or when the people they know that they are being studied, they would demonstrate some behavior that are biased, or typically they are actually biased toward what the researchers expect to see, because they kind of know what you want to study, and they tend to behave in that manner. So there are lots of studies that have demonstrated this fact. And another very important factor is, so I believe in human-computer interaction research, we need to have a multifaceted evaluation. So when we study machine user interface, the UI design is very important, but how user interface might influence clinician patient interaction, that's also extremely important. And then how the system design could affect team communication coordination, that's again very important. And social technical factors, organizational and external influences. So the bottom line is human-computer interaction research requires very careful design, and we need to attend to all different levels, all dimensions. Otherwise, we may miss some important factors or some important outcomes of a poorly designed human-computer interaction interface. So it's a very quick view about my previous work in human-computer interaction. So today I'm specific. My topic is specifically about how do we quantify the health IT's impact on clinical workflow. For those who are not very familiar with health IT, or I just have a few slides to bring you to set up this stage. So many of you know that in the U.S. We have several policies around year 2009 to try to stimulate the adoption of EHR. So meaningful use is an incentive program that provides a monetary award to hospitals and clinicians who are able to demonstrate meaningful use of a certified EHR. So after a few years of practice, now we are actually still at the stage of debating whether health IT is a good tool or not. So you see, Rand Corporation, they published a paper a couple of years ago to defend their report they produced in 2005, which project significant saving, cost saving, if the entire country goes with adoption of health IT. So what they mentioned, so Rand, they wrote this article, and they argue that health IT systems have not demonstrated satisfactory results because sluggish adoption of health IT systems. And choice of systems are neither interoperable nor easy to use. And the failure of providers and institutions to re-engineering their care process in order to accommodate health IT. So the point is not easy to use, and the need to re-engineer care process that both related to workflow. So if you think about that, so workflow integration is absolutely critical to make sure that the IT does no harm and also be able to achieve their design objectives. Very similarly, ONC, the National Coordination Office of Health IT, they published this paper. They found that recent literature shows predominantly positive results of health IT adoption. But still, they acknowledge that there are negative findings have been noted, and also most of those negative findings appear to be related to workflow implications of implementing health IT. So I just want to set up the stage that implementation of health IT have significant impact on many dimensions, and they affect practitioners' job satisfaction, they affect provider-patient communication, they affect efficiency, quality of care, patient safety. But on top of everything, it's a workflow impact that's actually underlying many of those negative results. So health IT and patient safety, and again, that is a significant topic nowadays in terms of how health IT implementation may introduce new type of errors. And again, enhanced workflow is one of the reasons that this particular report, the Institute of Medicine report on health IT and patient safety, they found that a lot of those patient safety events engendered by use of health IT is because the lack of workflow integration. So that really sets up the stage why workflow integration is so important. Because health IT implementation, they change workflow, and which has a chain effect of changing people's behavior, of introducing barriers to effective work, and then cause a lot of issues such as quality of care issues and as well as patient safety events. But to study workflow, it requires a lot of careful design, and I'll show you why. So I'm going to show you, demonstrate the approach of quantifying clinical workflow using two sample studies. The first is within EHR application. So workflow, you can define workflow in a very broad sense, how people work in a healthcare organization and with interacting with other people. But also, within the system, within a single system, there is also workflow in terms of how a person navigates from function A to function B in order to complete the work. And the second study is more generally, when we implement health IT, how do we evaluate the impact on workflow before and after? So the first study focuses on one single system, workflow within the system, and the second study focuses on the overall impact. And before I go to these studies, I want to acknowledge my collaborators. David Hanauer has been a collaborator with me in Michigan for many years. Michael Riley, who was also one of the designers of the study, and Michael is also now the chief medical information some officer at Apple And Danny is my PhD student, and Tara is my PhD student. So the idea is quite simple. So as I showed you, this is the user interface of a very typical EHR. The information is organized under different tabs, and the information is also organized on different boxes within each individual tab. So how do we find out how clinicians are using this particular application? How do they access information, and how do they enter information? This particular design, if you are a computer scientist, if you are familiar with relational database design, so you can probably make an association with this particular UI design with this backend database design. So my theory is the reason we design user interface this way is because computer scientists, that's their view, that's how they conceptualize the world. So if you are familiar with relational database, so basically what we need to do is identify those distinctive tables to store different information. So appointments, vital signs, vaccination, patients, physician, they are all distinctive entities to a computer scientist. And then we try to normalize this to reduce redundancy of data as much as possible. And that's how the computer scientists view the world. And reflected in the user interface design, and that's actually how computer scientists see the world. Not necessarily how physicians see the world or clinicians see the world. So, which may represent some fundamental conflict between the designer's view of the information, how the information should be stored and displayed, versus the end user's view, how the information should be stored and displayed. So we designed the study, try to kind of see if that's the case. This particular application, so we designed according to a typical clinical workflow. So this is a desired navigational flow. And we lay out different functions on the screen. So the screen is multiple screenshots. We put them together to show you the entire application. But the idea is that it's arranged in a way that we expect the doctors will be using this particular application, using this order. As I can imagine, when we actually present the system to the users, they have a lot of different ways of using it. So the objective is to do the mining of the data to see if, based on people's navigation of the system, whether we can use that data to reconstruct navigational flow that may be reflective of their information seeking and sense-making behavior, as well as their thought process in caring for patients. So we did this study in ambulatory care, primary care practice. 30 internal medicine residents use that system. It's non-intrusive. Again, it's a system that we have been deployed for a long time, and we connect data for a 10 months period of time after the system was implemented for an extended period of time. So we enable those features using letters. Assessment plan is A, retaking BP, B, diagnosis D, and so forth. So the idea again is computational infography. So we don't send people to the field to observe clinicians' usage of the system. Instead, we implemented different ways of capturing the mouse events, the clicks, and so forth. So we can actually tell which patient, which encounter that is, which links to the patient ID, and which clinician is, time, stamp, as well as the event type. The event type is access of a particular function. So once you have this data, how do you quantify workflow in terms of how do you know whether their workflow is desired or is anticipated based on the design or not? So what we did is first we used sequential pattern analysis to kind of uncover frequently reoccurring segments of feature access. I will also use hidden markov chain to predict the probability of future feature access based on the current feature that the person is at. Just give you some very simple examples. So these are different sequences representing different sessions of patient visits. So history, medication, order, medication, physical exam. So that's how a doctor access different functions in a particular patient encounter. So if you see this, you'll see that there are some quite distinctive patterns that has already emerged from the data. Medication, current medication list, and order. So those are two functions that clinicians tend to access next to each other repeatedly. And also assessment plan diagnosis. That's also another two features that people tend to access repeatedly next to each other. And physical exam and system review. Then if you put multiple patterns together, you will see a higher order of patterns. So in this particular case, assessment plan and diagnosis is always follow system review and physical exam. And also, you see that medication order, so those are also a particular type of sequence, a higher order of pattern that may emerge from the data, and may indicate the sequential order of function access, which is the sequential order of clinicians' thought process when they process the information and also when they enter data into the system. And Markov chain analysis is very simple. So once you have the sequence, you can predict, you can calculate the probability of an event occurring after a current event. So in this case, H is followed by M, H is followed by A, and you can calculate the probability of each event following the other. So the results are, so we calculate the percentage of usage across different features. You'll see that assessment plan, order, diagnosis, medication, history will be presented on this. Those are 5 top most frequent accessed features in this particular EHR system. And sequential order patterns. So I only showed consecutive, meaning that there's no gap between the events. So AD, I already showed that this is a frequently appearing segment of events. So it's assessment plan diagnosis. So when the people write assessment plan, that's also when they start to entering ICD-9 codes into the system as to indicate the diagnosis the patient has. And XADA, it's a higher order on top of the first pattern, so which is physical exam. So physical exam occurs before assessment plan and diagnosis, which makes sense. You have to do physical exam first before you start writing or laid out the details of assessment plan. And similarly, order medication, so very frequently combined action, and so forth. So from Markov chain, we can construct the probability of an event occurring after another event. So in this case, so if we know that the condition is right now using medical side effects, the particular function, then most likely the next axis will be G, will be allergy. So those are kind of a probability based on the empirical estimated based on the empirical data. So we know that different probability that another event will follow this particular event. So if we have that probability of events, of the sequential order of the events, then you can actually construct a view from the beginning of the encounter to the end of the encounter. So how those functions are likely being used in this sequential order. So if you see here, so most likely the transition will go from here to here, from test to assessment plan, from physical exam to assessment plan, and so forth. And if you have this probability transition matrix, then you can construct the multiple chain. So basically give you a view of when this patient walks into the room, what's the most likely feature that the doctor will be using, and what's the next most likely feature the doctor will be using. So because our data set are not large enough, and also assessment plan is being used very frequently. So we have this after the third step, the data converts to assessment plan. But if you have a more variation in the data, you may be able to see more distinctive steps. The implication is that assessment plan, according to the design of the system, is placed at the bottom of the page. Because the assumption is you have to do all this physical exam, document the medication, document different type of information before you start writing assessment plan, which is typically the last step of the visit. But in fact, we found that clinicians, they tend to document along while they are in the interaction. So they start writing assessment plan quite early on, and then they switch between assessment plan and other features of the system very frequently. So meaning that their day-to-day practice may actually deviate from the recommended way of practice of information assessing and patient assessment and information access and retrieval. And there are a lot of unintended ways of using the system. And because of that, it may actually diminish its utility in a way that if we have a reminder or clinical decision support, they got to enter the data first before our decision support are able to accurately, comprehensively producing computer-based recommendations. But if they use the system in a different way than you designed, it's very possible that when they are reached where the medical decisions are made, the important medical data has not been entered at that particular point in time. Then your system may not be able to achieve its design benefits. So with this information, we can also calibrate user interface design to better align the workflow with clinician's mental model. So as an example, so based on what we learned, we can easily implement some features to make navigation much more effective for clinicians. So we know that from medication to order, they frequently switch between those two functions. Then we can design shortcuts such as refill and also other kinds of shortcuts to make the transition much easier to do instead of many clicks and many mouse movements. So it's a first study demonstrating that within one single application, we can study a clinician's workflow by examining their navigational patterns across different types of functions. So as a healthcare system, when we introduce Health IT, we know that the Health IT will introduce significant disruptions to workflow. So how do we quantify the disruption? So we know exactly what happened, what kind of change were present before and after system implementation. So we know that a workflow is going to be significantly affected by implementation of Health IT. So this particular citation is from National Research Council. And from the literature of unintended adverse consequences, we also know that more on new work for clinicians and unfavorable workflow issues. There are top two unintended adverse consequences for implementing Health IT, and particularly computerized order entry systems. But when it comes to workflow studies or quantitative studies that tries to quantify the impact of Health IT on time efficiency and also on workflow, so what we see in the literature is that not much change. So little extra time, if any, was required for physicians to use this particular system. Implementation of the e-prescribing was not associated with the increase in combined computer time, writing time, and also system does not require more time than a paper-based system. And following implementation of EHR, the average adjusted total time spent per patient across the specialty increased slightly, but not significantly. So if you see those quantitative studies, they are pretty consistent, at least from the time efficiency point of view. They all found that use of computerized systems are not causing significant increase in clinician time. But as I showed that, people complain about it. They said that more work, new work, is top one unintended consequences that they felt being interrupted by use of IT systems, and also unfavorable workflows. So why there is a discrepancy between the literature on unintended consequences and the literature of quantitative methods that tries to quantify the impact on time efficiency and time and workflow? Well, my argument is those quantitative studies, they focus on time distribution. So if you work an 8-hour shift, how much time you spend on the direct patient care versus how much time you spend on computer. So that may not differ a lot between among those studies. But those studies are not really about workflow. So my objective is to quantify workflow, the disruption introduced to workflow by implementation of health IT. And there are two components of workflow. One is work, and the other is flow. And if you think about this, the previous studies are all on time efficiency, how much time you spend on computer versus patient. So they did not capture the flow part of this critical concept. So we designed the study and conducted this study at University of Michigan Health System. The idea is we conceptualize clinical workflow as temporal distribution of tasks, meaning that those are time sequence, ordered events, which constitutes the workflow. And we want to find out the hidden regularities underlying the data in order to identify patterns in sequential clinical task execution. So we used a couple measures. One is time allocation, which is consistent with what the previous quantitative studies have been using. So proportional time spent on different clinical tasks. We also developed some new measures. So this is a very important measure, workflow fragmentation, the rate at which clinicians switch between clinical tasks. So we believe that task switching is a very destructive activity. So if you engage a clinician in very frequent task switching, the clinician will feel they will have a perception that they are doing more work, and they are also more easy to make mistakes. And the other is workflow pattern, so regularities in their sequential execution of the series of clinical tasks. And I'll show you how we actually capture, how we recognize patterns from the workflow data. And the task switching cost, so the cognitive load, physical effort that may be incurred when switching from one task to the other. So switching task switching is not universally the same. From reading a paper chart to talk to patients is not the same cost as reading a computer or entering data into a computer while talking to the patients. So this particular study was conducted in a pediatric intensive care unit at the University of Michigan, and the intervention was a CPOE, computerized prescriber order entry system. So we used time and motion to connect empirical data. So basically, independent observers, they followed clinicians and then try to use some tool to time what they do, and also location and duration of the task. So we observed 20 residence conditions before, 16 resident physicians, and 20 sessions before and 22 sessions after. And we use iPad tool, so basically we capture different kinds of events, that different kinds of clinical activities a clinicians might be engaged in, and also capture the system will automatically capture how long did the particular task last. So the sample data is actually very similar to audit trail log. We do have a duration, and we have starting time and ending time, and we have different tasks and sessions. So from this data, how do we tell what has been changed in the workflow? Well, first of all, time allocation. This is, as I mentioned earlier, this is a measure which is consistent with previous studies. So what we found is the only change is indirect patient care reading. So reading from computer charts, for instance, but the magnitude is very small. So it's even though the pre-post change is significant, but the actual proportional time is very small. So it may not be very critical. And this finding is consistent with previous quantitative studies. So basically, across the board, there's no significant change in terms of how clinicians allocate their time across different types of activities. But then people ask, then again, the question is why people complain that they would add to their workflow. Why people complain that they perceive to be doing more work and new work, and they perceive that their workflow has been disrupted if there's no really change from time allocation point of view. So this is a visualization from the data. So the upper part is pre-CPOE, and the lower part is post-CPOE. So different colors indicate different type of clinical activities, and the duration is proportional to how long to the length of the color bar. So, well, from the visualization, what would you be able to tell? What happened? What are the major differences between pre-CPOE data and post-CPOE data?
Or switching of activities.
Yeah, so a lot of switching of activities, a lot of short segments of colors, which represents a much shorter duration of doing a task before the clinician needed to switch to another task. So this is very significant from the visualization. You can tell that this is a very significant difference between pre and post. So we can quantify that. So once we know that's one of the major that we should rule in, we can quantify the task transition frequency. So this is, as you see, this visualization shows you the frequency of switching between different tasks before and after CPOE. As you see that from walking to rounding to computer rate to computer use has significantly increased after the CPOE. So clinicians, when in the past, the transition was very minimal from talking to the patient to writing or reading the paper chart. But now they actually have to find a computer. At the time, there was no mobile, there was no tablet and other kind of mobile devices. So they actually need to find a computer in order to read the charts and enter data. So that's a significant increase of transition. And we'll see many other transitions related to computer use also increased. So meaning that computers are indeed introducing some disruptive effects to the workflow. And so if we calculate the continuous time spent on a clinical task, so before it was 163.5 seconds, and after it's 107 seconds. So basically, clinicians were able to spend longer period of time working on a single task before they need to switch to another task, before the CPOE implementation. And afterward, they need to spend a much shorter chunk of time working on a task before they switch to another. And significant before and after. So we also find some interesting the differences in terms of across the times of the day. So one significant difference is from 7 to 8 a.m. Pre is 21.4 minutes. They are pretty much doing the same thing, talking, conversation, versus post, 3.3 minutes. So that's pretty much the pre-rounding sessions where clinicians meet and to talk about the patients of the day. And there is a significant difference during that particular time frame in terms of how much time or how concentrated clinician team could be before and after the use of the system. So, in this particular study, we did not design experiments to kind of test out whether it is true that frequent task switching is associated with more cognitive interruption. But we do have a lot of papers from the literature, cognition literature, which shows that interruption and task switching is indeed affecting memory, affecting attention, and affecting the accuracy of human performance on tasks. So, in terms of sequential patterns, we also find some interesting change. So, for example, rounding to paper writing, it's the most frequent task switch before CPU implementation. And afterwards, to rounding, it's a talking rounding and walking, and talking rounding to computer use, and walking to. So basically, you will see that talking, rounding, and walking and moving, they become much more frequent, meaning that the clinician team they are talking with the patients during the rounding, and then they need to physically move away from bedside in order to use the computers. That's what this pattern tells us. Well, so in conclusion, implementation of CPOE based on our study, they had very little impact on allocation of physician time, so which is consistent with previous quantitative studies of workflow and time efficiency. But we did find that post-implementation workflow became significantly more fragmented. So that's how we said that we used some new measures trying to quantify the change to the workflow. What we found is time allocation is not a major factor because there was no significant pre-post change. But the most significant change comes with the fragmentation of workflow, and essentially that's a measure of task switching frequency. So this change, as we observed in this particular study, it demands more frequent task switch, therefore more interruptions and potentially higher level of cognitive node. So we implement the tool, and you can find this particular paper we discuss in more details. And some other researchers are now using the tool and also using these new measures to study the workflow impact of house IT. This particular study was done by a faculty member at Columbia University. So many people are now using this kind of approach to model workflow, especially to measure the impact or change introduced by the use of house IT. Well, so in conclusion, my view of current stage of house IT is like this. They look like functional, and they are indeed functional, but inside out, it's not the technology that we desire. It's far from a state that we desire. And also, from the user interface point of view, if you read this cartoon, I tend to believe that sometimes it's just the vendors, it's not necessarily intentionally create those barriers, but they sometimes don't care. And that has become a very significant issue of creating unusable IT systems that I've been using. And workflow interruption, cognitive interruption, those are symptoms of the poorly designed IT systems or poorly designed IT implementation processes. So I do believe that it's still a long way to go from what we have now to a very usable, effective information technology design for clinicians. And it will take a lot of engineering, a lot of consideration of human factors, as well as a lot of more accurate measures in order to assess the actual impact of health IT. And we cannot trust some of the data which shows, we will have to respect the data in terms of if there are certain qualitative studies, they show that the people were complaining, yet the quantitative data does not show any difference. So we have to look at different dimensions. Maybe we missed some important measures which are really telling the truth about why people felt or perceived that way. So with that, it's my presentation about for today. Thank you very much.